Good evening and welcome to Thursdays with NAMI. My name is Peg Morris and I'll be your host tonight. I am the Assistant Director of NAMI North Carolina. That's the National Alliance on Mental Illness of North Carolina. I'm so glad y'all are here. Thursdays with NAMI is our way of building conversations, authentic conversations, and building community around the topics of mental health. Our subject tonight is involuntary commitment, also known as IVC. To be clear, when I say involuntary commitment, I'm referring to inpatient care, involuntary civil commitment for inpatient care. So that's what IVC is going to mean for the purpose of this program. Of course, IVC is contentious. The stakes are very high. If I'm committed to a psych ward, the best case scenario is that I'm pretty darn uncomfortable, angry, disoriented for a while, but I come out feeling better, more on track with my recovery. The worst case scenario is the worst. It could be traumatic from start to finish. I could end up leaving feeling worse than when I started, maybe permanently worse. It can be very traumatic to be involuntarily committed. I choose not to get treated for cancer. No one will take away my freedom. But there are always a lot of sides to these very difficult issues. I once read a story of a therapist on the West Coast who passed a homeless woman on his way to work every day. And he would say hello, they would chat a little bit. But when he crossed that line of asking if she wanted any help, she would become very angry and abrasive. I don't want you, get away from me. I don't want you near me. I do not need your help. So he left her alone. And time went by. A couple years later, he was at a gala for a housing agency. He looked at the program, looked on the stage, and was amazed to see that that woman was the speaker. She was giving her testimony, and she looked amazing. You know, she was very much in recovery. And he heard her story. She was so transformed, and he said to her, congratulations, it's wonderful to see you. And she said, well, it's no thanks to you. You left me on the street when I was clearly not sane. So what is the right thing to do in these very thorny situations? It's not easy to make these calls. One thing we do know is that the rate of involuntary commitment has been increasing in many states, including North Carolina. Why is that happening? We've got 4 fabulous guests, really strong leaders in their fields. And they're going to be helping us understand IVC, what it looks like, what it should look like. We'll be chatting with them in just a few minutes. As usual, the first part of our show will be an interview with our guests. Partway through, we'll show a video of the week, and then we'll spend time answering questions from you, members of our virtual studio audience. Now, a quick word from our sponsors. Thursdays with NAMI is funded in part by Dr. Law's employer, the North Carolina Department of Health and Human Services, Division of Mental Health, Developmental Disabilities, and Substance Abuse Services through the Federal Community Mental Health Services Block Grant Fund. We are grateful for their guidance and their support, truly. All righty. So we're going to move right along. I know you all have amazing bios. Since there are 4 of you, I'm going to let you tell a little bit about yourselves later, but quick introductions. Cherene Caraco is the CEO and founder of Promise Resource Network in Charlotte. It's our biggest peer center in North Carolina, very successful. Corye Dunn is the Director of Public Policy at Disability Rights North Carolina. They do a lot of amazing work for disabled communities and making sure that individual rights are respected. Dr. Michelle Laws is the Assistant Director for Consumer Policy and Community Engagement at, as I mentioned, the North Carolina Department of Health and Human Services, Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. And she formerly worked at NAMI North Carolina, so she's family to us. Sabah Muhammad is the Legislative and Policy Counsel for TAC, the Treatment Advocacy Center, big leader in mental health, big leader in setting policy and working to ensure that people have access to good treatments, especially the seriously mentally ill. Welcome, guests.
Thank you. It's great to be here.
Thanks, Peg.
Yeah, so we always like to know the background of our guests. I'm going to invite you to tell your stories in a nutshell. And why don't we go in alphabetical order of the last name? So we'll start with Cherene.
Great. Well, thank you so much, Peg, and to our other panelists for this really important conversation. My name is Cherene Caraco, and as Peg said, I'm the CEO of Promise Resource Network, which is a peer-operated organization out of Charlotte, North Carolina. We serve people that are uninsured or underinsured who have experiences with serious mental health issues, co-occurring substance use, homelessness, and former incarceration. And we are an agency of 65 amazing people with lived experience, same background folks that we support. And I'm also the project director of the statewide movement for mental health consumer, Your Voice, North Carolina. I came into this very honestly. I was 13 years old when I came into mental health systems. I walked into my first psychiatrist's office, received my first of what ended up being 9 mental health diagnoses. And unfortunately, what was seen through the lens of pathology was actually my experience with childhood sexual abuse. So the first 6 years I was in services, I was actually experiencing abuse at home, but my behavior was seen through the lens of pathology and illness. And so the adults in my life, including the treatment providers, didn't recognize trauma. And I had to spend many, many years unpacking my experiences and healing, not only from my own personal trauma, but also from the experiences I had as a service recipient. I have been working in mental health now for 30 years, internationally, nationally, in many states throughout the country, and have seen firsthand in all of the work that I've done, personal experience, some of the failings that our system has. And I will just say this as sort of my last point. My last suicide attempt, so I'm a suicide attempt survivor, my last suicide attempt came directly in response to a therapist at the age of 19 threatening me with involuntary commitment. And I made the decision at that time that I would literally rather die by suicide than to be handcuffed and shackled, brought into an emergency department, having my rights removed. And more importantly to me, the biggest fear and concern I had was being body searched and cavity searched and watch while I bathe, because I am a sexual abuse survivor. And that would have been the absolute ultimate for me in terms of re-traumatization. So I do a lot of effort around the state and around the country around understanding the impact of involuntary treatment, both an involuntary inpatient commitment, and how we can differently engage people in their recovery process through non-coercive healing-based alternatives that understand trauma and culture and poverty and some of these other social justice issues related to mental health recovery. So thank you for having me.
Well, thanks to you, Cherene, and you always tell your story in a very compelling way. You've done a lot of great advocacy. You sound great. We're losing just a word every here and there with your audio. I'm not sure why, but I thought I'd let you know. Corye.
Hi, thank you. I'm Corye Dunn. I'm the Director of Public Policy at Disability Rights, North Carolina. I'm an attorney, but I don't come to this work primarily through the law or first through the law. I come first through personal experience, through my own lived experience, but also through my experience as a family member to the mental health world. Now, I will say that even before that, I was in the disability space around intellectual and other developmental disabilities. And so that service system is sort of my first home professionally. So advocacy was a natural outgrowth of service to me. And that has taken the form of policy advocacy on behalf of the legal rights of people with all sorts of disabilities at Disability Rights North Carolina, which is our state's protection and advocacy agency. We are an independent nonprofit, and our job is to advocate for the legal rights of people with all sorts of disabilities across the lifespan and across settings.
All right, thank you. And Dr. Laws.
Thank you, Peg and Gary, and all of you are right, family members at NAMI. It's an honor to be on this panel tonight with all of the guests. I am, as Peg said, one of the assistant directors for the Division of Mental Health, Developmental Disabilities, and Substance Use Services. And I really came into this work also, through my own lived experience in terms of mental health, as well as being a family advocate for many, many family members, trying to access resources to address both mental health as well as substance use disorders. Throughout, I can't remember when I wasn't advocating for our families and in the area that I grew up in, and as well as areas that I lived in later. I come from a historically marginalized population. For African Americans in particular, jail is the #1 service provider for mental health and substance use. And it's not just African Americans, but if you're poor, and if you are someone who came up through systems, foster care, and so the interest of those persons, those individuals, has always been something that's not only a part of the work that I do intellectually and professionally, but in my heart. I carry, when and where I enter, stories, personal experiences, and a lot of it laden or the foundation of which is trauma, whether it's racial trauma, sexual trauma, violence, you name it. There's been someone that I've advocated for. And so I came back. I once worked at DHHS and for the Division of Mental Health during the first system reform. So back in the early 2000s under Secretary Bruton and then later Secretary Carmen Hooker Buell Odom. But I came back because, I was seeing system failures all across different sectors. And it was important for me to be at the table because I had the privilege of being at the table. Access through education, through making it out of public housing, going on to get my different degrees and access to different political capital that gave me a sense of responsibility to reach back and to always remember those who are still in similar environments that I grew up in. So that's why I'm at this table. And on the state side, on the policy side, on the programmatic side, is because I know what can happen when systems fail. And somebody has to be at the table who knows what can happen on a very personal level when systems fail. And so I'm honored to serve under an amazing leader, Victor Armstrong, and Chief Deputy Secretary Cody Kinsley, and a secretary who gets it. And was very privileged, I think, and honored to serve in my capacity, even short term, for NAMI North Carolina, one of the leading advocacy organizations across the country. So.
Right. Well, you definitely got that seat at the table, and I'm glad you're at our table tonight. And Sabah.
Hello, my name is Sabah Mohammed. I serve as Legislative and Policy Counsel for the Treatment Advocacy Center. I am also the inaugural DJ Jaffe Advocate, meaning that TAC is taking a pivot to proactively reach out to underserved communities who experience barriers to treatment based on racial and cultural identifiers. In that role, it's been very important to talk about what it means to come from a marginalized group and then be marginalized within a marginalized group because of the nature of severe mental illness and access to resources. I came into this work initially when my loved one was diagnosed with paranoid schizophrenia, and that quote that has empowered me and haunts me every day by Victor Armstrong, that most African Americans encounter the mental health system for the first time through the back of the police car, speaks to my family's experience, speaks to the experience of many clients that I've had as a former public defender. And it's important that we do this work to make sure that becomes a falsehood, and that we use the tools that we have to make sure we are reaching out and being the true advocates that we say that we are. I unfortunately had to watch my loved one just deteriorate for probably a decade without being able to integrate any help, without getting any treatment. My loved one is currently still in a long-term facility because they just simply languished untreated to being unrecognizable, unable to help themselves, and a harm to themselves and the community. I started doing advocacy work because I had to do something when I realized it was the law that was creating these barriers. That's how I reached out to TAC, and I became a family member advocate. That led me to just every day I would say, I'm only going to do what I can do. And then one day I start getting calls from other people because I was now the advocate in this space, and that shocked me. I wasn't ready to help. I was just a big sister with a sick sibling trying to change the world. And that led to becoming a legal advocate in this space because it's still what is needed. And I don't know whatever the call is next. I'll keep doing what is needed because as long as there are family members out there who can hopefully avoid what my family has gone through, I want families like mine to be able to walk in the direction of ableism and healing. And we need to learn that I'm one of them.
Wow, wonderful. Well, thank you, Sabah. And Cherene and Dr. Laws, you've been here before. Corye and Sabah, I hope you'll come back. I can tell there's a lot more to your stories, and I'm looking forward to working with you. So our first question goes to Cherene. Cherene, in North Carolina, as you know, the number of involuntary commitments has increased dramatically in the past 10 plus years. That's according to a 2020 study by the peer center that you head up, as we mentioned, Promise Resource Network in Charlotte, as well as the work of an assistant public defender, Robert Ward, out there in Mecklenburg County. How did that research project come about? What did it look like? And what other trends did you see besides the increase?
Yeah, and if my audio goes out, please just give me an indication and I will try my best. So Peer Voice North Carolina is organized through topic-based coalitions. And one of our coalitions is called Recovery Alternatives to Forced Treatment, or RAFT. And the coalition is made up of people who have been impacted by involuntary treatment, suicide attempt survivors, family members whose loved ones no longer talk to them because of forced treatment, and providers that are very concerned about the overuse of forced treatment as our first line in engagement, if you will, of people with mental health issues, and then our public defenders. And Bob Ward, our local public defender, was very concerned about the rate of IVCs that he had seen locally in Charlotte. He is our one representative of everybody that is petitioned under involuntary commitment. So he came to me and said, Cherene, I can tell you anecdotally without data that this is very significant, and it is driving a wedge between family members. It is turning people off of services. It is creating more harm, and we are using them through involuntary commitment. And so as a coalition, we wanted to examine where does the advocacy points lie. And so we went out looking for the data. We talked with everybody from hospitals to managed care systems, the state of North Carolina, looking for this data. And what we were routinely told was, you're going to have to call county magistrate offices. Well, we have 100 counties in North Carolina, and the data is coded. So you can't just call up a magistrate to get this data. After talking to many magistrates and starting to gather the data, relationships, connections, we were finally able to get our hands on 10 years worth of data from each of the 100 counties from North Carolina. And we tracked it, we trended it, we graphed it, and we were absolutely shocked to see that as a state, we have a 91% increase in the use of involuntary treatment in North Carolina over 10 years. We started mapping it by counties and realized in my county alone of Mecklenburg, it's increased by 135%. And it led us to the question of, why is this data not being tracked or reported on in a transparent way? And when we start looking at the data, it's very macro level. We can't look at race and age and gender and ethnicity. We can't tell how many are repeat involuntary commitments, or how when somebody was petitioned in one county but transported to another county. We can't tell the reason for the IVC, whether it's for transport or whether it was petitioned in the community. We don't have that level of data that's accessible to us. And without it, it's very difficult to be able to identify why this trend is increasing so rapidly and what are the areas that are contributing to it. Our suspicion is it's a combination of a lot of things, from fear of risk in the provider community to a paradigm that is not toward recovery-oriented systems, to community mental health systems that have really broken down in significant ways, to lack of engagement in voluntary options, and to policy issues around transport and other things that are likely contributing to what we are seeing. I give you more information about the trends, but without micro level data and somebody examining it, it's very difficult to distill from the data we do have around why this has been occurring at such a high rate.
Mm-hmm. Okay. Any follow-up?
I do want to say how important the data are for us to track as a state. But the reality is, the data that we have access to is commitment data, and it looks different than the data that, it's not petitions, it's actual commitment data. And it looks a little different. We've just started, I think, really leaning into this space. And Cherene is right. This is, there's so many gaps and so many things that we don't know. But what I can tell you is, and I'm looking at some data now so we get data from all of the, approved IBC facilities in North Carolina. And if you look at data from July through December 2019, there were 17,484 actual commitments. January through June of 2020, there were 14,784 actual commitments. So we're not seeing this, spike, this upward trend that some of Cherene's data that they've looked at suggests. What we do know is that petitions are higher than actual commitments. And I think that's important for us to lift up in this conversation. And when we also think about, medical acuity, degree of aggression, all the different types of things that go into, the decisions that are made, I think that some of the data that we're seeing is we're not seeing people IVC, at least the data that we're looking at, that have low medical acuity, low degrees of aggression. And also, I know we'll get into some of this later, so maybe I'll save it later in terms of the revisions to the IVC laws in North Carolina. And I know Corye will probably talk to some of that. But the point I just want to make is that we need to make sure that the data that we do have, that we're interpreting it correctly so that we don't send this panic and fear in communities where they are dealing with community members where this is an appropriate response. And the fear, when I say fear, the fear that all IVCs are bad, and that North Carolina is just not doing this right. And so you're better off trying to figure out what your loved one or the person that you're concerned about, how you can best serve them in communities. Now, I'm for community solutions as the first response, as the first thing that we look at. But I also know enough about persons in which IVC has actually not been as traumatizing as it has been for others, and has actually saved their lives. I'd much rather, for example, so under my management, I guess, at DHHS is our customer service. and client rights, consumer rights. And I can tell you what scares me is when I get an update that a gentleman, with an SMI has been released from a psychiatric residential treatment facility into a homeless shelter. They haven't shown up to take their meds. Their family member is concerned because this particular person is a huge Black male. This is just one example, a huge Black male that acts aggressively, and that they're afraid, the family is afraid that if police are called and they are not on their meds, they're not in treatment, they're not managing their SMI, that it will end fatally. And so to take away, and they want to know that if I have to IVC my loved one versus allow them to just be out there in the streets in a psychosis, experiencing a psychosis, I want to know that I have that tool. And so I think, I know I've said a whole lot just really around the data piece and then tied in some other things, but I did want to make that point that for us, the commitment data, sure, we need to look at it. We need to have more access to the demographic data. I would love to see the demographic data. But I can tell you the commitment data that we see, and we haven't, done a trend analysis to see, what those numbers look like. But from just that year, and I asked for 2021, and I have that as well. But
could you repeat the numbers that you said earlier?
Absolutely. So to our facilities, and there's a link on and I will drop our link into the chat to the designated IVC facilities in North Carolina. So you can't just take people anywhere. They have to be a North Carolina designated facility. So from July to December 2019, the number of commitments was 17,484 commitments.
Okay.
And remember, we could be talking about multiple ones. There's some cases I know that is so disturbing to me, where some people have had within 1 year, 17, 15, commitments, IVCs. And that speaks to a whole nother issue, right? That speaks to something else, right? So that's 17,484. From January to June 2020 was 14,784. And then the total number under 2021, let's see. That's the same from July to December. So the data I just pulled up is the same. It breaks down the degree of aggression, medical, so the primary reason, the number of individuals, and so forth.
So Peg,
so I just want to say that for 2021, from January to June of 2021, we're at 20,872. And again, that's commitments. If you look at individuals, 2,673 for mental health, 183 for substance use, 22 for mental health and IDD. And so persons can be IVC'd multiple times, which to me speak to a whole nother issue where where there's system failure.
Right, yeah, and there's kind of that Pareto principle always where 10 or 20% of the population is using 80 or 90% of the resources. I think Cherene has a comment now.
Yeah, I just want to respond. The data that we had gotten was directly from AOC, the Administrative Office of the Clerks. And in 2018, it actually showed 110,000 IVCs in North Carolina petitions, but actually involuntary commitments. And Corye can actually speak to that even more because she also looked at the raw data. We actually analyzed it as a group to make sure that we were understanding the data that we had ourselves, but it was 110,000 in 2018.
Petition.
No, it wasn't
Petitions,
petitions.
though.
I think that we'll set aside for now the difference about what data we're looking at, because the data Dr. Laws is citing, we've never actually seen before. And we've asked for it. So we're excited that that DHHS is looking at it. We're really looking forward to getting some meaningful information out of that.
Yeah.
I think that from a rights perspective, I am troubled by increases. I am more troubled by any case, one or more cases, where someone is IVC'd because we failed them before that. And the vast majority of the time, that's what we're talking about. We hear a lot of emphasis on the need for an alternative for folks who don't have insight into their condition, for conditions that do not lend themselves to that sort of awareness, for people who are so severely symptomatic that there are few other options. I want to emphasize that that's not the vast majority of who we're talking about here. People are IVC'd for suicidal ideation. People are IVC'd for expressing a wish to harm themselves or others when they are experiencing distress. We have, story after story of people who are IVC'd because we can't transport them to the treatment they voluntarily present for. We are overusing a significant legal tool for a whole host of reasons that don't make any sense, and that we should be ashamed of, frankly, as a state, right? We should be ashamed of the fact that we don't have a mechanism to get people the help they want without abridging their civil liberties, without making them physically unable to leave treatment if they so choose. Because I can tell you that for a lot of us, that's a real disincentive to seeking treatment. And that's a problem. We have created that problem ourselves, right, as a state. So I want to be really clear that any unnecessary IVC is an IVC too many. And that I'm unconcerned with arguing about data that we haven't all seen here, because there's literally not a single one of us who's seen all of the data. I am much more concerned with talking about why we overuse this tool and how do we use it less.
I agree with you 100%. And that's why I said the issue is not so much whether or not, because I don't know that we are seeing such significant increases, because again, I just don't know. And the data we have is different from the data you all have, and so forth and so on. And so, but what I agree with you, Corey, on what troubles me is when one person can have 15, 16, 17, 18, 20 IVCs in a year. That to me suggests, as you said, that we're using this, possibly this very important resource that could be of value to some families and individuals, possibly inappropriately. And I also don't know, and that does, I see Bibi mentioned the language in House Bill 734. I'm thinking that's what she was referencing, that we did change under General Statute 122C 255, the reporting requirements to include method of transportation and the numbers of people IVC, but or transported at any time between a 24-hour facility and so forth. But I do think we need to look. I am all about equity, humanity, and justice, period. I don't think anybody, all of us, can say from our backgrounds and our experiences, we represent on a personal level as well as professional. People who are depending on systems to work right and for their rights not to be violated. I won't go as far as saying I, as a Black woman with Black brothers and nephews who've been, I want systems to work right. So whether it's advocates pushing us from the outside, DHHS, Division of Mental Health, working with disability rights and see, what I don't want to do though, because of differences on how we get to where we are all trying to get to. I just don't want to incite fear and panic when we don't have to. And I don't want to use this problem that we have, that we've all acknowledged. One, in some cases, it's not being used appropriately, but where's the data to even show that, right? Anecdotally, it should matter. I'm all about anecdotes. I'm all about, empirical data, qualitative data as well as quantitative data. So all I would say tonight is we need to stay at the table, all of us, trying to get this data right to give all of us better visibility into what's really happening, not from an emotional, agenda, whatever, but from the perspective of really understanding what is going on. And I'm not sure we all do understand, have visibility into what's really going on, because the data, as we mentioned,
What's really interesting to me as I listen to this is your observation, Michelle, that Black families, people of color might need that backup tool to make sure their loved one gets into care without being shot, just to put it very bluntly. If you call 911, you get a police officer at your home, and that might not end well if you're a Black male in particular. And Corye, your comment that people end up using IVCs, or they end up having it as that last grasp at services, that somehow the system fails them, they don't have access, they don't have maybe culturally competent access that works for them. And so they get painted into a corner of using IVCs just to get any treatment at all. So it just seems like this is a tool that's being used in different ways. It's being used off label more than I realized.
I would say my experience in working both with respondents to petitions for IVC and also mental health care clinicians who participate in the IVC process and public defenders who represent respondents to petitions is that very few of the cases that they see in front of them are what any of us would hope IVC would be limited to. And I think that there's a consensus here that we wish that we could use IVC less, and that we don't want to see it used unnecessarily or inappropriately. And I would argue that when we do that, we actually create further barriers to treatment because it scares people, because because we transport people for IVC. I want to be really clear. We heard that it might be helpful to IVC someone in lieu of having police response. That's who picks your loved one up when you take out a petition and they have to go find your loved one. And we have seen people shot and injured and killed in the process of executing an IVC. So it is not an inherently safer tool. It is completely coercive. And I'm not saying it should never be used. I am not saying it shouldn't be an option. I'm saying we overuse it because we have failed to adequately cultivate a system of community-based supports and address the stigma associated with seeking treatment voluntarily.
So Corye, can I just add to that? I appreciate those comments so much. There's a couple things. Number one, in addition to the bill that we submitted to get IVC data routinely tracked in North Carolina and evaluated, we submitted two other bills because they were connected to this issue. One is to create other alternatives to involuntary hospitalization on the front end for prevention and diversion and crisis response, to engage people in things we find helpful in healing. And then the third one is to create non-police community response teams. I see that. The third one is to create non-police community response teams in every community in North Carolina. So if somebody's experiencing emotional distress due to mental health issues, substance use issues, issues around homelessness and poverty, even welfare checks, that the police are not the responder issues. We have seen in our community, when we introduce CIT, crisis intervention training in our community, our IDC rates rose steadily. And we do a lot of training for our police officers here. I ask them routinely, why is that? And they say the same thing. Number one, we don't want to respond to these issues because we're not trained to do this. Number two, we are told that you need to IVC people. That is the only tool we are being given. And if that is the case, if we're going to divert people from police involvement, so we definitely, I think, all agree that police should not be responding. The question becomes is diverting to what, right? We have defaulted to hospitals because we haven't built out the other end, as Corye said, of compassionate and engagement and culturally responsive and understanding poverty and understanding trauma approaches on the front end to prevent from hospitalization on the back end.
Gotcha. I would love to hear Sabah's thoughts. You look like you have something to say.
Well, from a treatment advocacy center standpoint, we are always going to be on the side of the data that looks at reoccurring petitions for IVC. We're going to be on the side that says what happened to the integrated services to check back in on this person, to make sure that this person's family was even informed about what was going on. Who in the community is this person's caregiver? Because that's the calls we get. We get the calls from the parents whose loved one has suddenly changed, and there are absolutely no answers or resources for people who lack insight. And if you don't believe insight is real or that anosognosia is real, then the very symptoms of delusions and hallucinations keep someone trapped in a situation where they are too sick to volunteer. I think I've coined this term as the untenable space. We are not living in distress. Our families are living in crisis every single day, waiting for an emergency that we can't gauge because it's harm to themselves or others. We watch our loved ones deteriorate for weeks. There are no services in that untenable space. We wait for police, and we live in a state of fight or flight. It is untenable for family members. It's untenable for our loved ones who lose decades. And the problem is not simply one component of this mental health system. It's the larger view that we're dealing with 50 different experiments with limited funding, forcing us to compete for resources that are already there. Most of the resources are being geared to the criminal system, which is serving no one. And we don't have the luxury to dismiss involuntary commitments when they are last ditch hope at anything. We want to come to the table. We want to stop having polarizing conversations and talk about what actual resources exist or need to be imagined to fill that untenable space that gives our people who are too sick to choose a direct line to incarceration, homelessness, death at the hands of the police, or worse, just watching them have no access to their own dignity and potential for decades. That is what we need to be addressing collectively, because with all the data, we cannot be conclusory. We cannot know the answers. Healthcare is individual. It's whether you're rural, city, whether your caregivers are strangers or actual blood family, we don't know. We have to be ready to pivot and address from the marginalized in. And that means people experiencing financial barriers to treatment, language barrier to treatment, and racial cultural barriers to treatment. When you look at those people and work in, you save everyone in the process, or at least if we won't, there's no one silver lining answer, but when we look to the marginalized inward, we start to fix this whole broken system on a more substantial level.
Mhm.
I
Well,
love that. And I want to, Peg, may I add also the importance of community solutions, community treatments, but also the importance of, we talk about class, culturally and linguistically appropriate services. I met with a group of minority providers out west. We also need to make sure that we are adding in the pipeline of service providers, minority providers who many of the historically marginalized populations can relate to, who understand. Victor Armstrong gives an example, him laying on the sofa of a white female clinician saying, my sex drive is low, I don't feel like getting up in the morning, and I kicked my dog and yelled at my kids. He's just not, that's just not the,
that's not going to happen.
It's not going to happen. And why is this important? We also track children in ED data. And that's also an area that we all need to be at the table without an agenda, without, trying to polarize it. As Sabah said, I love that. And I love that untenable space too. But 45% of the kids consistently, we just started, I asked for the data by race and ethnicity. We've just started really looking at it. 45% are Black kids, 22% are white. When we look at kids that are stuck, languishing waiting for a placement, the last kids to get placed, guess, Black kids, right? And don't add Hispanic and Latinx with language barriers, family members that don't know how to navigate systems.
Or DSS involvement, Dr. Laws. Or DSS involvement.
Or DSS involvement, exactly, right? And so I think,
let's say what DSS is, maybe somebody.
Department of Social Services.
So child welfare.
Our state, child welfare. So this issue, of whether it's involuntary confinement or admissions into emergency department psych wards or units, is something that should be concerning to all of us. And we should look at ways that we can use the data in a way that makes the system better, as opposed to creating alarm and panic. And I think we do a good job with the latter. All of us do. I really want us to be able to understand what the data are showing us, so that we can build up programs and services to address the real true needs, and that's where I want us to be. All of us have a role in that. And I think sometimes, we miss that part, that piece.
Yeah, I agree with that, Dr. Laws. I know I'm only going to speak for my own community and our role in it. We serve several thousands of people a month that are uninsured, that live in poverty, and frankly have been kicked out of mental health services because their behavior is too aggressive, or they quote unquote lack insight. And in the 16 years we've been doing that here, we have petitioned one time for involuntary commitment, once. And that was because somebody was attempting to die by police. It's not that it's magical. Our engagement of people voluntarily in things that are helpful, people will show up if they see themselves reflected, as you said, in the service providers, if the services are actually helpful to people, if it is empowering people to still have a life and experience emotional distress, if it understands the implication of trauma and culture and all of these other things, people will show up. We have proved it over and over and over again. We do nothing that is court ordered. We work in 6 specialty courts, and we are the one service that is not allowed to be court ordered. Because for us, voluntary engagement attraction is what makes this work so much for people that have been kicked out of services, kicked out of systems, or have felt so incredibly harmed, oppressed, and marginalized by systems. It's not an accident that we've had one IDC in 16 years. There's a lot of work that goes into establishing that level of trust. People, it's relationship based, and they're going to show up for things that they actually find helpful. harmful.
Yeah, well, it seems like there's a whole lot of common ground here, and I'm sure the data disconnect will get worked out over time. We're all interested in solutions. What do we want those solutions to look like? Obviously, Cherene has a good start on that.
So I put together a slide, but I won't pull it up. I'll just read from it. So, you know, I do think that the state is taking steps in the right direction. We've got Corey to make sure that we do.
You can pull that up if you'd like to. Go ahead, share the screen.
So one of the, you know, I did say I do want to just reiterate, first of all, the challenges that I think we should overcome, that we've got to overcome, and we've said that police should not be the first point of contact or first responders to a person in a mental health crisis. Point blank, period, end of discussion. We have seen how that never ends right. Rarely does it end right. I'm not saying that all police don't know, and I'm not even saying that crisis intervention trained or CIT trained, because I know that's something that NAMI has worked extremely hard on, and I think we need to continue to do that. But I do believe that we need these multidisciplinary teams that are going out with clinical professionals, peer support specialists, patient navigators, community health workers, and that response needs to be a coordinated response. I also believe that we do need to lean in more to culturally and linguistically appropriate and trauma-informed care, especially for African-American communities, you know, who are reminded every day of George Floyd and Breonna Taylor and so many of the unknowns, the American Indian population that has been traumatized from forever, and our immigrant population who continues to be traumatized, and refugee population, quite frankly. And so I think we need to build up systems, look at our community, public especially, because many of the people, the historically marginalized populations, are either Medicaid, underinsured, or uninsured populations. And then also we need to look at why there's a lack of community alternatives to IVC, and where we need to build up those community alternatives is where we need to direct funding, as far as my recommendation would be. I do think that we've started taking steps in the right direction. Conversations with and listening to stakeholders, and diverse voices at the table with the same common interests. I would not question anyone on this panel, where they're trying to get us in this state. I believe everybody's heart is in the right place. I believe we all want to see involuntary commitments only used if absolutely necessary and as the last resort, and used according to the law. But I also think we need to continuously look at and lean into what revisions we need to make to our IVC law in North Carolina. We've started, made some attempts at that, but these are just some things that I think I'm hoping that we can agree on, and that's where we need to be focusing our energies and our efforts at this point in addressing the IVC, what is perceived by some as an IVC problem, overuse of IVC in our state. And understand we can't fix what we don't know, so we need the data, but we need to make sure that we're analyzing. We've got all the data points and data sets that are available, and that we're analyzing them in the right way that leads us to better understanding, like I said, what's going on, and not, inciting any fear. I do want to, just on the data part that I mentioned, I did pull the 2021. And so we do see an increase from 2020 in actual commitments. And these are data that was reported from, that we have access to. The administrative offices of the courts, depending on, we've asked too. And so sometimes we get data that may not actually be the commitment data, but it's the petition data. And so I do want us to be cautious, think about.
Dr. Laws,
what
can
we
I
do.
ask you to, can I stop you? Because I've never seen this data before. So I'm really excited to actually
Yeah.
be able to engage with it. What
Yeah.
I'm looking at looks like January to June 2020 compared to January to June 2021 is a
Yep.
50% increase.
Right, so I said the 2021 data is showing an increase. We didn't see
But a
that from 2019
50%.
to
Wow.
2020 to 20. Well, I mean,
Over the same 6-month period. I mean, I just want to acknowledge that there's something there. I don't know what it is.
There is something there, and
There's
it's a little
something
less
there.
than 50%, right? I'll have to do the.
It is like 47%.
I'll have to do it. Yeah, I'll
In
have
my
to do
head,
that.
sorry.
But either way, you're right. I mean, there is something there. And what I'm most concerned about, Corey, that we need to look at is, like I mentioned before, and let me pull up that data maybe too. So let me stop sharing for 1 second and pull up the other. What's concerning to me.
So I love all the data. I just want to step in. We do have questions from people in the audience. So if we want to, maybe we could give this a couple more minutes and then take people's questions.
I am concerned, and we need to take a look at, are the multiple commitments of one person? Because that data.
We're doing something wrong if somebody
that
needs
data represents
multiple.
And that data represents, in terms of individuals, and I have to do quick math on this, right at 3,000 individuals.
Yeah, I mean, that's a big deal. And I also want to, I mean, I think multiple commitments of a single person is a troubling number that we need to keep track of. What is even more troubling to me is multiple commitments of a child in a single year, which we see frequently, and which parents tell us is their only way to access services when they have been actively seeking services for months and months and months. So no, we've talked about IVC as if it only applies to adults who have full control over their own lives.
Yeah,
and we see
yeah.
kids IVC over and over again because their parents can't get them any services in a less intensive setting than an emergency department.
And let me say, we do need to unpack that on a whole nother level, because, and this is, if I can take off DHHS, DMH hat for a minute, this is a community member concern. When over 45, and then sometimes depending on what data, 50% of those kids are Black. Service providers, what is it about these kids that you don't want in your programs? And that's a conversation that the African-American community is beginning to have. Why is it that you won't take a big burly looking Black kid who's huge for his age? He sits, but you will take, a blonde haired, blue eyed boy from, right? And so I don't want us to go down this road today without really being willing to have a conversation. It's not a lack of services in some instances. It is.
It is.
That's part of it.
And I think that where there is scarcity, Black kids are gonna experience that much more acutely than white kids.
Absolutely.
Yeah. Wow, there is a lot to unpack here. I think we need to line up a monthly show or something to really sink our teeth into all of this. Really good conversation. I'm going to take a pause real quick. If we could wrap up the interview portion of the show, because we've got lots of questions in the Q&A. I love to see that. Someone commented in the chat they're not being answered. We do answer them towards the end of the program, so thank you for your patience. And I know we've got some great panelists, so you want to hear more from them on your questions. I want to thank the people working behind the scenes tonight, psychiatric nurse Gail Pruitt and executive director Gary Kreitz for always being there. They're always keeping things going in the chat box and on Facebook Live. That's just so important. I think I'm going to forego our video of the week because we've just got so much meat on the bone here and I want to get it covered. First question comes from Kent. How many IVC providers are there in North Carolina?
So we have about 123 facilities that are designated as IVC designated facilities, but they can be under some are under the same UNC Center for whatever, UNC Center for, so some of them can be under the same actual provider, but the unit or the facilities are broken down as separate or pulled out as separate. So
for example, Dr. Laws gave the example of UNC, but like even in a psychiatric residential treatment facility for kids, each unit can be licensed separately, or rather an acute care facility.
Yeah, so about 171.
Okay. Question from Allie, is IVC on the rise nationwide or is it specific to North Carolina? I can tell you that the UCLA did a report, the Social Welfare Department. Again, in every state, the data is hard to come by. They went through what they could and were able to call enough data from 22 states to find that there was an increase between 2012 and 2016 of about 13%, which outpaced the inflation rate growth by 3 to 1. So it is an issue apparently nationwide. The average really is strongly about that. Apparently in California, Allie writes, people are taken in on what they call 5150s. We call it IVC. They're often released without enough time to treat. I think every state has that problem as well. Beds are at a shortage, so they release them to the streets. Family members who try to get treatment and services for loved ones find the system prohibitive, and those who need services end up in crisis, are in danger, have to run with the legal system, and end up incarcerated. I agree with all of that. Panelists, any comments?
I do want to say that the laws in every state set quite a high bar for involuntary commitment. And in every state, it is illegal to file anything false with a court, with a clerk. So you do have, there is some order here. Like Dr. Laws was saying, it's not about fear. Until we know the conclusion of the data, we need to look at other things, bed shortages, lack of integrated assertive resources that ignore people who are too sick to volunteer. We need to look at hospital closings, the racial, financial, economic divide, and we have to start coming to the table to figure this out. Each state is going to have different data. It's always impossible when you are working separately like we do to try to figure this data out, and we all need it to mean something for each of our organizations. But if we start there with knowing that we won't come to this until we come to it together, we will get a good start in figuring out, is there something that's good for every single state? And if it's not, what's the framework you go to make sure your state is being served the best possible way that it can? We have to sort of build the templates that were ignored and respond to crisis and the utopia we want to see in the future.
Mm-hmm. Well, thank you for mentioning the hospital closings. That's sort of been on my mind throughout our conversation, is deinstitutionalization, which started as early in the 60s. Many of us know many psychiatric hospitals that were state funded were closed between the 60s to the 80s or 90s. The ideal was to have community support, wraparound services. The new meds would pretty much make mental illness a thing of the past. For some reason, the developmental disability community got a good package out of that. The mental health community, not so much. Cherene, did you have something to say?
No, I'm listening.
Okay, I thought you unmuted, so I got my hopes up. Any other comments right now? If not, I'll go on to Virginia's question, which is next in the Q&A.
I just want to affirm what Allie was saying about what she's experiencing, or I don't know your pronouns, but what you're experiencing in California, which is people are being IVC'd. They don't have long enough to even engage or to receive any treatment. Then they're being discharged to the streets. And that is absolutely what we see here as well. And part of it is access barriers. We talk a lot about Medicaid expansion, which I agree with. However, if we are expanding an existing array of services that create so many barriers to people engaging, then expanding the same types of services is not going to further around these particular than we're talking about. And so part of it is looking at the opportunity on the front end to prevent and divert from the need for an involuntary commitment and right size it. There is a space for hospitalization, but it is not right sized. We are using that as a first line of defense in so many different examples. We talk about somebody that's too sick to voluntarily engage. And, you know, I get cautious about that assessment of too sick. When I was 13, my first psychiatrist said I would never be able to go to college. I'm a Syracuse University grad. I went to Rutgers working on my master's degree. He was wrong. And I've had many treatment providers that were frankly wrong, because partly they're looking at the wrong things, partly as they were assessing through their lens of qualifications, partly it was lack of knowledge of me and who I am, and it was pushing me into a pathology, illness-based identity that I fed into for many years until my involuntary commitment threat when I attempted suicide. That was the point that changed my life at the age of 19. And the reason why is I decided at that moment that I was walking away from mental health services, and I was no longer going to subscribe to an illness-based identity that I was being pushed into over and over and over again. I was compliant for many years, and the more compliant I was, the sicker I became. I wasn't able to move forward in my own recovery until I developed my own wellness and self-help connection to other recovering communities, seeing other people that had also moved beyond the labels of illness. We recover. And as a matter of fact, the majority of us that have been labeled with SPMI, because I've been to diagnoses, actually do recover with the right types of opportunities. And of course, the hope that it's not only possible, but it's actually probable.
And I want to say, I mean, add to Cherene's experience starting at 13, add to that Black skin, nappy, kinky hair, parents who don't act right, who don't show up, and providers don't want to have to deal with. Add to that, layer that over, layer race and colorism within race over her experiences. And that's what Black families experience and individuals experience. That and some.
Absolutely.
Right?
And I just want to share, my father was born on a reservation.
And also think about in our system, we don't have a good public system that is nimble enough to meet the needs of where people are. And so when you say people are being IDC'd outside, you know, they're put out in the streets and shelters and so forth, some of it's because our system will treat the individual but won't prepare the families. And so when people have burnt through capital, when families are like, look, I love them, I know this on a personal level, I love them, but no, she cannot come to my house. I've said that unashamedly. I've said that. And so because neither me nor my husband nor other family members were equipped to deal with what our family member needed. And I am not alone. There are many families across race and ethnic groups where people have burnt through the capital at home. And so our system,
the financial, emotional, social, all of it. Yes.
Social.
Yeah.
So it's not just, it is, yes, we don't have the right services and systems built up, but we also need to have a system that responds to the whole. When we say whole person, that includes family members that don't want to give up on them, but they don't have the resources and the tools. And that's why I like some of the programs that NAMI provides for family support to help people understand how to navigate and how to advocate.
And also to heal family units, right? Because trauma is not, trauma doesn't just happen in a bubble over here to this one person. It's frequently multi-generational.
Absolutely.
And people who don't have the skills to keep themselves, to address their own traumatic histories, it's very difficult for them to support a loved one whose trauma manifests in a serious mental illness.
That's right.
Stop talking about my family.
It's all of our families, Peg.
I wanted to make it clear that too sick to volunteer does not speak to a label of any kind. It speaks to, especially something that can't be overcome. It speaks to a condition that is being ignored, to the people who are allowed to languish untreated. It speaks to the fact that there are some people, there are two Olmsteads, people who will be able and be much better off and go into recovery in their community, and to people who will be a harm to themselves or others and may not thrive either temporarily or for a long-term amount of time. I'm speaking to too sick to volunteer means if you need housing, you can't fill out any application for SSI on your own. So you can't have the luxury of saying, don't label me. That label may be the only housing your family can afford. It may be the only place to get you into an ACT team or into AOT. And without that, you languish on the street. It speaks to the family members who call us because their loved one was too sick to not walk into traffic and lose their life.
Yeah.
If you build it and it takes them 30 years to come and they've experienced homelessness and preventable tragedies, that's not effective. And it has to be something to speak to those people. We're getting diagnosis through incarceration. We're getting stabilization instead of treatment, and nothing is adding up. Not enough is adding up to long-term well-being for the group who is not able to come here and speak today.
Absolutely. Thank you for that amazing summary. I would like to get to some more of our questions. We've got 15 that we haven't answered, and one from Virginia on Facebook.
I'm not optimistic of us getting to all of these back.
Well, we're gonna give it a little shot though. If you have access to commitment data from facilities, this is to Dr. Laws. If you have access to commitment data from facilities, what data points are included in that data set? How many of the questions posed by PRN and DRNC could be answered with that data? I think that remains to be seen.
I think we're really excited to see it. I mean,
yeah, I don't know what questions PRN and DRNC has. So I think that's a offline conversation. Send the questions to us. I can tell you what data points that I've looked at and referenced tonight are total number of individuals receiving treatment under the IVC petitions in these IVC designated facilities. For each primary presenting condition, the number of individuals receiving treatment under IVC petitions, number of individuals of whom IVC proceeding was initiated at this facility, and the number of individuals whom IVC proceedings was initiated at this facility, the number that were referred to a different facility, and each primary reason for referring individuals, the number of individuals that were referred to a different facility by primary reason, degree of aggression, medical acuity, or other. And mind you, the numbers are petitions versus referred versus actually IVC versus referred out. So certainly this is data we will definitely share, and any questions. I don't know what questions she's referencing.
Yeah, I mean, obviously I have a ton of questions related to all of that, but I just want to say that we've been trying to get this data out of the Administrative Office of Courts. And we would find it much easier to get it from a partner like DHHS, and had previously been told we just are never going to be able to produce this data. So it's not everything we want. We obviously want that demographic breakdown. We want more detail about diagnoses and treatment modalities. Honestly, like when we say someone is IVC, that's a legal proceeding. That's not a kind of treatment. It just means we're locking somebody up for treatment, yeah, but it doesn't actually mean one type of treatment or another, right? Like it means so many different things.
So I think you're reading, so I'm hearing something interjected or injected into this. We're not calling it a treatment. We're simply reporting the data as it is as IVC petitions and actual referrals.
Yeah, no, I agree. So I'm suggesting we would love to hear more about what those treatment modalities are.
And y'all, I'm still fixated on our questions here.
Okay. Okay.
So does anyone know about how many threats of IVC are used to get voluntary admission compliance?
We're never going to find that number.
Yeah, I don't know.
That's an unknowable giant number.
So that falls under the category that we as people with lived experience call coercion. And coercion sounds like this: if you don't take your meds, you're going to be involuntarily committed. If you comply with the treatment programs, you're going to be kicked out of your housing. If you don't do X, then we are going to do Y, which typically means either withholding services, threatening a legal petition, or kicking people out of services. That number, we can't even begin to get the numbers on that. I can't tell you the number of times that was done to me when I was in services as a mental health patient.
Wow. All right, and we're still on our speed round here. Question from Tawana. Are mobile crisis units the bridge? Would that help with this IVC problem, this linkage?
High quality mobile crisis would be a huge step in the right direction.
I agree. Yes.
Okay. And mobile crisis, of course, is where people go out to your home to do an assessment and offer services. It's not coercive. It's just services that come to you when you are in crisis.
The thing that leaves open is when your family is living in crisis, when the bar is too high, and then we hear reports of individuals like Daniel Prude or Walter Wallace who would not have gone with a mobile crisis unit because they didn't have the awareness at the time. We're still working on the answers. I would love to come to the table to have the police not be called when everyone knows there is a threat, yet it didn't arise to harm, but that threat is going to wake everybody up the next day without any resources to long-term care or connection to. So it will be a bit of a bridge, and our people will still be here trying to figure it out, the bridging the rest of the way. But even step by step, let's do it together.
I love that. A few years ago, it was related that all police would be CIT trained as part of their basic training. This is from Julie. What happened to that initiative? I can tell you CIT, which stands for Crisis Intervention Team Training, it's still going. I don't know the prevalence. I don't know how many are trained, but I believe it's in most North Carolina counties. Gary, our executive director, is on this Zoom. He might put some helpful information in the chat box. But CIT is a training where police officers go through 40 hours of intensive training to learn the basics of mental illness and to de-escalate, at least in theory, a situation in which mental illness is a factor.
And I'll just add that it also included a good deal of information in some CIT courses about developmental disabilities, particularly including autism spectrum.
Thank you. All right, next question. I'm so excited we're getting through these. It takes your qualifier to be willing to seek peer support and community resources in order for a person to work and be successful. How do we as caretakers bridge that gap in order to limit IVC? What resources are available for families? Sabah, I have a family member in that space.
Well, I just want to say there was a family member that was in the chat. I hope I am not, because you put it in the chat, that I have spoken with their family numerous times. They have a loved one in this situation that we're talking about that happens routinely with us, where people are so averse to treatment engagement because oftentimes because of IVCs in the past, we see many people that have had 5, 6 IVCs that are not going to come near clinicians, they're not going to be engaged in therapy, and they're not going to do anything voluntary. As a peer-run organization that does not operate through billable services, we have the ability to work with those families and those individuals. So they call us directly, and we find ways to connect and engage and support. We are able to be very creative and very innovative, as I think this family member could attest to, because of the way that we do operate. The fact that we don't have this throughout North Carolina is something that many people have been working on for many years. these type of safety nets need to exist in every single community in the state of North Carolina. We are the safety net in our community for people that are not otherwise engaging, that do not have insurance, that have been kicked out of services, and their behavior is considered too complex for a lot of provider systems. The fact that we don't have this in every community in the state is definitely something to advocate, consider advocating for.
Okay.
But we do have peers in every county almost, except out on the far eastern part of the state, which we're trying to build up that. And you know, the outer areas of our state, far west, far east, we definitely need to do more. But there
Yeah,
are
and
some
while we
areas,
have
some areas that are very resource rich, like a Mecklenburg, but we still have issues. So I was in a conversation with Corye Mack, who's the president of NAACP there. We still got work to do. So even where there's still a lot of work that needs to be done in that space. And I'm a huge advocate of peer support. I say the family members, long before peer support was a thing, was acknowledged as a paraprofessional, I call it. Cherene disagrees, but as a valuable service in our service array, our continuum of services. Many of us were peer support specialists to our loved ones. You heard Sabah's story about being that sister and advocating. And also some of us, you know, managed our mental health issues, conditions in a way that was helpful to family members who weren't able to. So I do think we need to really look at this continuum of peer support and figure out a way to, as Cherene said, get as many services up and running, because we've got a lot of unemployed peer support specialists during this pandemic, by the way.
We do.
We tried to help.
We do, and I just want to clarify, while we have peer supporters throughout North Carolina, mostly they are working within behavioral health settings or clinical settings or medical settings. The reason why we are able to be as accessible and zero access barrier as an organization is because we are an independent, standalone, peer-run organization that doesn't require referral, it doesn't require a clinical assessment, it doesn't require an authorization, and it doesn't require insurance. As a matter of fact, August 6th, we're opening our peer-run respite here in Charlotte, where people can come voluntarily for up to 10, I know, right? People can come voluntarily up to 10 days and be surrounded 24 hours a day, 7 days a week by other survivors of suicide attempts, psychosis, serious mental health issues, homelessness, who are providing healing, trauma-based support regardless of their insurance type, their history, or their ability to pay. Those are the types of resources, as you ask questions, what are the alternatives? If we had those options available in every community, we could potentially divert a portion of these IBCs from happening.
We've got some really good information in the chat from BB Smith. We have a clubhouse model also in North Carolina, also based on voluntary engagement, following the model designed by Fountain House in New York. If you've ever heard of that, that's a really wonderful example. CIT update from Gary. There are approximately 21,000 CIT officers, that's crisis intervention team trained officers, spanning 85 counties, give or take. Interesting question from Facebook. When you refer to a petition, is that a 72-hour hold, or is that the full IVC of court-ordered civil commitments? Corye, Sabah?
In North Carolina specifically, it's only a 24-hour hold. Tax policy recommendation is 72-hour hold, because you really want to get a sense. You don't want people to just time out and start the cycle over again. But the petition is the emergency evaluation, which starts the process to see if a long-term treatment or an inpatient commitment is required.
Right. So they have 24 hours to conduct that assessment, what they call first assessment. So that the petition gets you to the 24-hour hold or to first assessment, whichever happens first. They have to complete it in 24 hours or you are free to go. And then if that assessment indicates a need for further confinement, then and it could end in a number of ways. It could end with voluntarily seeking treatment. It could end with you know, with IVC, but it could also end in a crisis resolving, because we do see sometimes when someone is IVC'd in crisis and they're removed from the situation where the crisis occurred, sometimes that has actually resolved in 24 hours. But I want to be really clear that everyone who is petitioned is confined for some period of time, right? So it's not like it's not like it's an immediate, like you get your IVC petition and you appear in front of a judge immediately. You're confined for some period of time, and anything, you know, any ability to confine our fellow citizens, right, in our community members and our family members needs to be handled really cautiously and with a lot of care and precision.
Yeah, absolutely. And I was just reading an article about someone who was graduating from college, and she had suicidal ideation, but she didn't have a plan. She really didn't meet the whole ladder up of suicide questions. Do you have a plan? Do you have materials to carry out your plan? Do you have a time frame? But she was held and strip searched, and that's just so common. Apparently they're looking for objects of danger that would relate to suicide attempts. But wow, how traumatizing. Gosh.
Yeah, and Peg, I will say, if you look at some of the other research, multiple sources of research demonstrate that when somebody is involuntarily committed due to suicidal thoughts, release, suicide attempt rates increased by 100% within the first 4 days of release from a psychiatric hospital. And, you know, I am a person that is in that category, and I know multiple people that attempt suicide post an IVC because of what happened during the involuntary commitment or the process, or, you know, just the traumatization that can occur. So we also have to be looking, I know my internet is unstable. We also have to be looking at the consequences of using the most restrictive approaches and how people are processed through the involuntary commitment procedure that is actually can do more long-term harm than help.
Right. Okay, Corye, you are correct. I don't think we're going to get to all of our questions. I so wish we could. We've got 3 minutes, so why don't we go with Gary's question? Where can we find hope? Let's end this on a note that will let us, you know, relax and get some sleep tonight.
I'll give you some hope. Here's some data hope. The majority of people, we have 14 longitudinal studies in place for people that have been labeled with SPMI, all with diagnoses of psychosis or some variation of schizophrenia. And what the data suggests is that the majority of us, 68%, actually fully recover our lives. As an example, in North Carolina, as an alternative, I just want to share, we have a warm line that we've been operating that as of yesterday, we've had 12,000 callers since the beginning of COVID, not one suicide attempt, not one overdose, not one 911 call, not one involuntary. 12,000 people have gifted us with the opportunity to help them through their emotional distress throughout the state of North Carolina in a year. Pretty significant and very hopeful to recognize that people are incredibly resilient. And if they have support and they have examples around them of people that are in recovery, it's amazing what can happen.
That's wonderful news. I just referred someone to your warm line. Go ahead, Dr. Laws.
We also have, you know, we're trying to, so there's a warm line in the West, Sunrise operates, and also there's one that we're standing up that Dr. Kimmy operates out of, that's hopefully will reach some of those people in the eastern part of our state, those five-finger counties and along the eastern borders. But I also want to, I think there is hope in understanding that people do recover. But Sherry McGimsey would have my head, Diane Crisanda, I see is on here, if I didn't say, but there's also a population that doesn't recover, in her words, a mom with a son with SMI who reminds me every time I use the term recovery, who says, look, cut it. My son, we understand where my son is in his illness, but that doesn't mean that he still should not be provided the best treatment and services that are available to someone as sick as my son is. And so Sherry, if you're on, I said what you always say. And so the other part, the other, however, I think you said 60%, the other 40% of people who are the sickest of the sick among our populations that we serve still deserves the best services and treatment
Absolutely.
that we can provide, that public dollars can provide. And so that's what we are working in at the division under the leadership that we have now in place to hopefully make that a reality. And then I also want to say that there's still a lot of work being done. As wonderful as PRNC is and the work that they're doing, there's still a lot of work there's still a lot of historically marginalized populations in particular that for whatever reason, and in Charlotte and in Chapel Hill and in Durham, in Pasquotank, in Yancey and Mitchell counties that are not that for whatever reason are not having this kind of success that the 20,000 or I forget the number that Cherene gave that they reach. And we need to figure out what's going on with that population, because they are in areas, some of them, where there is a Promise Resources network, Promise Resources and a peer-run organization. And they're not doing okay. And we need to figure out that population.
Those are all our people. Yeah,
those are all
absolutely.
our people. And suicide is going up among certain young people.
And overdose death. And
Okay. Let's circle back to the hope question.
yeah.
Well, the hope is that we know where that's the hope. We want to let people know we see you. We know you're there. And we're not gonna paint this. Sometimes the hope is in saying, I see you. I'm thinking of that movie that had nothing to do with this, but when they see us, we see you. That's the hope.
Gotcha. Yeah, that's well said.
I think being seen and being connected is such a crucial part of all of this, right? Like, I'm a lawyer, the lawyer part is boring. We don't want to infringe on people's rights unnecessarily, but we also know that human connection is incredibly powerful as a tool for healing and surviving amid really difficult circumstances. So whether recovery looks like, having a life that looks like it did before the onset of symptoms, or recovery looks like finding a way to move forward in the presence of those symptoms and a way to be connected to your loved ones and your community. That's really it. And that's what community inclusion is about. It's not just, finding a bed here or a provider there. It's really treating all of these folks that we're talking about like they're actually part of our families and communities. Mm-hmm. And we're not doing that now, but I think that we can.
I love that. And Sabah, you want to take us out?
Yeah, I have hope that in spite of all the bittersweet preventable tragedies and traumas that we go through, that advocates will start realizing that advocating the intersections is going to help all of us get through this and go toward better treatment for all families. If you're a criminal justice reform advocate, you're really a severe mental illness advocate. If you're an advocate for mental health, you are really also a severe mental illness advocate, and we can come together. I also have hope. Our latest data from AOT is showing that hospitalizations are down nationwide, arrests are down in New York, length of hospital stays are down in Florida. If your county utilizes AOT, share. it's people who are already in the system, who already have been involuntary committed those 16 times that we were talking about. AOT is an underutilized tool. I put in Eric Smith information. It saved his life. He is now a public speaker and giving every family member whose loved one is unrecognizable the hope that if the resources are there and we assert them and we integrate them and we teach the family and the peers that their loved ones will come out of this and at least experience what Dr. Law said is their new normal. If it's not full recovery for the sickest of the sickest, it is participating in your own continuum of care and meeting you where you are and seeing you. That's my hope.
Well, I love that hope. Thank you so much for that wrap up. I need to acknowledge for those who don't know what AOT is, it's called assisted outpatient treatment. It's also court-ordered outpatient treatment. Some would even say forced outpatient treatment. I got to acknowledge both sides here. It was big in Ohio where I got my NAMI training because two families who had lost loved ones, their children, to suicide. One walked into traffic, just as you mentioned, Dan Knapp. They brought that law in place to give families a tool to help their adult children get care when they couldn't see that they needed help and were putting themselves at risk. That's going to be our next show. There are two sides to that issue, and that's, yeah, I just wanted to put all the sides out there. Thank you so very much for being here, all of you. I love your candor. You've all been eloquent and forthright, and I appreciate you. Please join us next week. We've got our own policy director. He took Michelle Law's chair, Dr. Michelle Law's chair when she left. Ashish George, he's going to be talking about South Asian, not perfect and totally fine with that. He's got a great story to tell. And incidentally, he worked for a tiger sanctuary in India before he came to us. So you hear all kinds of stories about the tigers. Please join us next week. It's been great having you all here. Thanks everyone for joining us.
Thanks for having us.
Have a wonderful night.
Bye.
Thanks, everybody. Be well.
Thank you.
Thank you.